Yeah. Oke, sudah siap semua? Ya, jangan lupa turn off handphone-nya, gadget semuanya. Okay, good morning everyone. Okay, how are you today? Okay, today we have our first lecture. He is Professor Ahmad from the Pharmacological Center in the US. He is expert in pharmacology and he also has a lot of experience in pharmacology research and also a lot of publication regarding pharmacology. So if everyone wants to know the basic pharmacology, everything you can ask him. This is time is limited for him, so you can ask anything. Yeah. So today we would like to share the transnational pharmacology of antimicrobial agent. So this would be 30 minutes, and then after that you can ask question after that. It's up to you. You can do it in English or in Indonesia, and how to translate it. Okay, so let's make a note if there's any question. Okay, Prof, thank you. Welcome to our campus Jatinangor. We hope you enjoy this. Okay, presenter is yours.
Terima kasih. Selamat pagi. I apologize for having this lecture in English language. I've been coming to London for almost 15 years, but my Bahasa Indonesia is not that good. I apologize. So my name is Rob. I'm Rob Eijnhuizen. I'm a hospital pharmacist, a clinical pharmacologist, a professor of pharmacology at Radboud University Medical Center, which is in Veranda, in the Netherlands, in the northern part of Europe. So I studied pharmacy in a small town called Utrecht. And this lecture will be about translational pharmacology of antimicrobial agents. I understand you already had some pharmacology lessons. Do you like it? I was afraid of that. Yeah, it's the same with Belanda. Still, I would like to help you and look through your pharmacological classes, because I think you already have some pharmacological classes now. Let's see how this works. Oh, that's the pointer. This is working. Oh, yeah. Technical issue. Terima kasih. So I will start with introducing the topic, which is I think you know a lot about tuberculosis. I'll introduce you to pharmacological research, and then we will go to the topic of today, which is translational pharmacological research. And I'll give you an example, which is about tuberculosis research on TB meningitis, tuberculosis in the brain and in the meninges. And I'll end with some words on patient care and on capacity development. Try once more. Still not working. Well, you know, tuberculosis is a very old disease. It is as old as mankind. And here you see a picture of a mummy from Egypt, which is being investigated by two medical doctors. And they have found a piece of bone. And in the bone, you see some lesion caused by Mycobacterium tuberculosis. Because as you know, tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. And Mycobacterium tuberculosis can affect the body at any location. Most of the time it's in pulmonary tissue, but it can also be in the brain, it can everywhere apart from your hair, and in your nails. Otherwise, it can be everywhere. And so this is the patient, the former patient probably passed away to tuberculosis. And at least in Europe, tuberculosis patients were treated in sanatoria. Was that the same in the old days in Indonesia? I don't know. There were specific hospitals for tuberculosis on sanatoria. And this is, well, the grandmother of all sanatoria. It's Sanatorium Schatzalp. It's in Davos. It's in Switzerland, also in Europe. And now Iberia is a very expensive 5-star hotel. But you see, the patients can sit outside and they are always positioned towards the sun. You know why that is? Come on. It's good for your, when you have to block. And the reason is that when you position yourself in the sun, your body will make more vitamin D. And vitamin D is acting against Mycobacterium. What you see here is a tuberculosis referral center in the Netherlands. This is actually where I was working. You see it's relatively similar to the previous one in Switzerland. Also with special balconies for patients to sit in the sun. And we just moved from this rather old-fashioned building to a new tuberculosis and high-level infection unit. This was built also because of the corona crisis and because of the Ebola cases, some Ebola cases that we had in Milan. Yeah, as you know, tuberculosis is transmitted by expiration, just like the coronavirus. There's a lot of similarity between tuberculosis and COVID-19. And many of the precautions that we take during this COVID epidemic, also the masks, they come directly from the tuberculosis field. For example, the 1 meter or 1.5 meter distance has been validated in treatment of tuberculosis patients. And this is what happens when the Mycobacterium tuberculosis is invading the lung. This is the artistic impression, a drawing. And here you see large lesions, they are called scavitations. It's like the bacterium eating itself through the lung pulmonary tissue. And what you see here on the right hand is a real lung, which is being studied by pathologists. And what you see here is cheese-like tissue, they call it. Caseous tissue. And it's highly infectious tissue with a lot of microbacteria in it. And you will not, and here you also see these very large cavitations. And you will not be surprised that the patients will have pneumonia, and fever, and they will waste, lose a lot of weight. Because tuberculosis in English language is also called consumption, which means that the bacteria are actually consuming the body. You lose a lot of weight. Well, the epidemiology of tuberculosis is no less than really dramatic. Here you see the incidence, which is the number of new cases in a certain time period. And this is, I think, from 2019. The incidence per 100,000 persons. And you see, especially in sub-Saharan Africa, the incidence is very high. It's more than 500 new people in each 100,000 people who develop active tuberculosis. And in Indonesia, you see the incidence is, well, around between 100, around to 100 up to 200 new cases a year. But the absolute amount of patients, the total number of patients is much higher in Southeast Asia because more people are living there. There are more 100,000 folds of patients. And as you know, about 1/3 of the world is latently infected with Mycobacterium tuberculosis. These people do not have active disease, they're not coughing, they do not have fever, but they have the Mycobacterium with them. Okay, tuberculosis for decades used to be the #1 infectious disease killer. Roughly comparable to HIV infection, much more death than malaria. But in the past 2 years, well, it's not something to be proud of course, but in the past years, COVID has dropped. COVID, it's not good. Smile once more. COVID has surpassed tuberculosis and has become the #1 infectious disease killer. But you have to realize that tuberculosis has been around for decades, for centuries, for thousands of years. And in 2019, there were 10 million new cases and 1.4 million deaths, among whom about 200 to 300,000 children. And there's also resistance emerging to tuberculosis, and that's really a fast-growing problem. Literally. Also in Indonesia, it's a big problem. Well, I don't know whether you like cowboy movies, you know, they occur always in North America. And this is a classical, I'm not as young as you are, this is a classical cowboy movie picture. It's called The Good, the Bad, and the Ugly. It had its 50th anniversary last year. So I thought I like this movie picture, I put it in my presentation. And you can say there's also the good when you are a patient and you have drug-sensitive TB, then you are in a fortunate situation. But there is also mycobacteria that are multi-drug resistant. So there's only few drugs remaining to which the bacteria are responding and that kill the bacteria. But there's also an emerging problem, and that's the extremely drug-resistant TB or the extensively drug-resistant TB. And then even the second-line drugs are hardly working anymore. And of course, that's a very unfortunate situation. This is a similar picture of the world, but now with respect to multi-drug resistant TB, especially rifampicin-resistant TB. Rifampicin is the most important TB drug. And you see it's a completely different picture. It's mainly in the former Soviet Union that there is a very high incidence of MDR-TB, and this is the percentage of previously treated TB cases who present again to the Puskatras or to the hospital, and they have multiple drug-resistant TB or rifampicin-resistant TB. And you see in Russia, it's more than 50% of the patients who have resistant TB, which means that the problem is really going out of control there. And that's also the case, by the way, here in Ukraine. You know, there is a world a war ongoing there in Ukraine, and we have quite some refugees. Here in the Netherlands, very small country, and we have quite some refugees from Ukraine in the Netherlands now, and we have also quite some MDR-TB patients now in the Netherlands spreading this, and we are not used to it. Indonesia, the incidence is not that high, fortunately, but still it's emerging. Okay, what is the aim of disease? Aim of the treatment is, of course, to cure patients, but that's important for individual patients. But from the public health perspective, it's important to limit the transmission. Of course, we want to prevent emergence of resistance. We want to keep our drugs. And we want to minimize the chances of relapse, which means that the disease is recurring. The bacteria, you know, Mycobacterium tuberculosis can also be in a dormant state in your body. So it can sleep for decades and certainly say, oh, here I am. And then it's causing a relapse, especially when you have immunosuppression. For example, when you had a renal transplant, you need immunosuppressive drugs. Then the bacterium says, hey, here I am. Unfortunately, there is no sufficiently active vaccine. So we in TB research, we very much envy the situation with respect to COVID-19. There was a vaccine in 1 year period, 2 year period, incredible. Whereas we are studying and looking for a vaccine for TB for decades. But the Mycobacterium tuberculosis is a more complex organism. It's evading all the vaccines that we have developed so far. And as you know, the same applies for HIV virus, which is a much more complex virus than coronavirus. Have you ever heard of these drugs? Azithromycin, rifampicin, pyrazidamide, and ethambutol. They are the first-line TB drugs. And you should give them in combination. Everyone, why should you give them in combination? Not just one drug or two drugs, even 4 drugs at the same time. Why is that? Someone who dares to speak up. No? Yes, please.
Thank you for the chance. Why we should give a combination of drugs, because it's been proven to be more efficacious in treating the disease.
Yeah. That's a good answer. Indeed, synergy. They strengthen each other activity. That's very important. And the other reason is, in this way, we try to prevent the emergence of resistance. So if a bacterium is resistant to one drug, isolate it, then allow it another drug that can kill the bacterium. Okay? But yeah, you can see this bacterium is really easily developing resistance if we really need 4 drugs. Keep it under control. That's why you have to use in combination, synergistic activity, prevention of emergence of resistance. You have to use it low for at least 6 months, and this is because of the dormant state of the bacteria. Antibiotics normally they do not work on sleeping bacteria. A bacterium has to be replicating, but anytime that a bacterium is awakening, then it should be killed by an antibiotic. But you have to wait for a long period. There is an intensive phase or the continuation phase of treatment, and it should be given daily, not intermittently. Okay, now these are drugs. I don't think you know these drugs. These are used for multi-drug resistant TB. So these are the second-line drugs, and they are subdivided in various groups. And you also have to give 4 drugs. So normally you hope that you can give these first levofloxacin, bedaquiline, and linezolid, and you add another one from group 3, B, I mean, and these drugs from group C, they are a little bit less. But the problem is often that the mycobacterium is resistant to one or the other drug, and you end up with these group C drugs, which are less efficacious and more toxic. Okay, now about pharmacology. This is the classical perspective of clinical pharmacology. This is looking through a pharmacological glass. So you are becoming doctors, so you will prescribe drugs, also TB drugs, and the patient is supposed to adhere to your advice. The patient should be compliant, and he should take the drug, or he or she should take the drug, and this results in a drug concentration in the blood, in plasma and serum, also at the site of action, in pulmonary tissue, or in the brain, for example, or in your toes, wherever. This is called pharmacokinetics. It's the relationship between the dose that you administer and the time course of the drug concentration. And this concentration in turn causes a certain effect, and it can be that's called pharmacodynamics. That's the relation between the concentration that you achieve and the eventual effect. And it can be desirable effect, effective treatment, but when concentrations are too low, this favors the emergence of resistance. So patients, you see, they should take their drugs, otherwise the concentrations will be too low. Drugs should be of good quality. There's quite some inferior drugs on the market that you can buy anywhere, and that do not contain the right amount of drug, and it results in a too low concentration. And then when concentrations are too high, unduly high, it may cause concentration-related adverse effects. And of course, this has a negative effect on the adherence. So this is all about adherence, it's about pharmacokinetics, it's about pharmacodynamics. But you see, the drug concentration is very important. It's in the middle of the picture. It's the intermediary link between the patient who should take the drugs and the eventual. Of course, this is a simplification. I'm a pharmacologist.
I'm a pharmacist, I'm focusing on drugs, but it's an interplay between the drug, the mycobacterium, and the host, of course, the patient, human being. Okay, this is called a pharmacokinetic curve. This is what happens when a patient takes a drug, and you see that on the x-axis is time, hours after intake, and this is what happens in the blood. And you see the drug is being absorbed, and there is a certain peak concentration, and then there is metabolism, and there is elimination. You can use all kinds of formulas to describe it mathematically. And this is the lowest concentration, it's called the trough concentration. And then you can, this is the total exposure, it's the area under the curve. And you can calculate it by doing integration. Now, for some antibiotics, the peak concentration is very important. Do you know any antibiotics for which the peak concentration is important? Have you ever heard about gentamicin, for example? It should be used parenterally, and it's really the peak concentration is important. You need a high peak concentration. It's giving an uppercut to the bacterium. Whereas other antibiotics, they need an effective concentration during the whole dosing, like beta-lactam antibiotics, penicillin. But for the TB drugs, the total exposure is important, the area under the curve. Okay, what do we do in pharmacological research? We describe this kind of process. We determine why some patients have high exposures and others have low exposures. This has to do with age or gender or ethnicity or with genetic polymorphisms in transporters. And in the end, we want to assess the relationship between concentration and efficacy and dosage. Okay, then what's translational pharmacological research? So, translational pharmacological research is a chain of pharmacological research, and it often starts with preclinical pharmacological research, which is research in cells or in mice. And here you see work that we have done in our laboratory. This is the Mycobacterium tuberculosis. It has a very thick cell wall, which is green in this picture. And you see that TB drugs are entering the cell. But the cell is defending itself. Mycobacterium tuberculosis is defending itself against the drug, and it's pumping the drug out of the cell. You see, these are called efflux pumps. And one of the things that you can do, and pharmaceutical companies are studying this, whether you can inhibit the efflux pumps. And this could be a mechanism of action for new TB drugs. Because then the concentration, you see in the right picture, concentration of TB drugs will be higher. Now, this is largely unknown for TB drugs. They have been on the market for more than 40, sometimes 50 years. They are really old drugs. But we do not know this kind of basic information. So a few years ago, 5 years ago, we performed a study in which we studied all the TB drugs here with all kinds of abbreviations, ethambutol, isoniazid, means rifampicin. And here you see all kinds of transporter efflux pumps in the Mycobacterium tuberculosis. And here we saw that, for example, this drug, clofazimine, is a very strong inhibitor of glycoprotein. And that's the most important transporter in the human being. And then this has not been known yet. And it means that clofazimine can cause drug-drug interaction with other drugs that are transported by PGP. So that's an example of preclinical pharmacological research. Then clinical pharmacological research. Then it's often performed in human being. That's why it's called clinical pharmacology. And it's often in small patient groups. And I'd like to show an example of a study that was actually performed in Bandung. It was the first pharmacokinetic study on a TB drug called oxyproxate. It's a fluoroquinolone antibiotic. Maybe you know cycloprox, used for urinary tract infections. And here you see, well, the abbreviations that I just showed, area under the curve, the peak concentration, the drop concentration. It was first described in Indonesian to be patients. And for example, the area under the curve, 0 up to 24 hours, is on average is 48 hours times milligram per liter. This is important information to determine the right dose of the drug. But you see there are actually two phases in this study. And this is because this was a drug-drug interaction study performed here in Bandung at the Sanatoriums Hospital. Here again, this is a pharmacokinetic curve. Here you see the pharmacokinetic curve of moxifloxacin, and this is when you add rifampicin, another TB drug, and you see there is a drug-drug interaction. Rifampicin is decreasing the exposure, area under the curve to moxifloxacin. And it means that across the world, when this combination is used a lot, we have to increase the dose of moxifloxacin. Not one tablet of 400 milligrams, but 1.5 tablet, 600 milligrams, based on this research project which was performed here at the Epidemiology Hospital and collaboration with UPA at my university as well. So this is a typical example of clinical pharmacological research. And you can apply the results directly to patients. Then there is, of course, clinical trials in consortia, not in small groups, but in very big groups across the world. Research consortia. And for example, I myself and colleagues, we are part of the so-called Panacea consortium. Panacea is a drug which helps against any disease. It's not existing, but yeah, it's a nice name for a consortium. And it's a European African consortium with 4 European universities and about 12 South African universities. And we are funded by the European Union. And this is a study that we have performed. This is not a pharmacokinetic curve, but this depicts on the x-axis the day after starting treatment, and on the y-axis the proportion of patients with culture conversion, which means the amount of patients who have no bacterium in their sputum anymore. And sputum is a kind of saliva in your lung. So you see there are 2 regimens here which are actually doing well. They are outperforming the other ones. It's the red regimen. It's with high dose rifampicin. And here the what is it, gray? It's the combination of rifampicin and moxifloxacin that we have studied before. It's doing quite well. Well, not optimal. About 50 to 60% of the patients have cleared the mycobacterium after 2 months of treatment. So you see, you really have to take a drug for a long time. So this is not done in one center. This is a study with hundreds of patients. You need multiple centers. This is only in Africa, which is a little bit suboptimal. Because ideally, you would like to have Asian patients, African patients, Caucasian patients, because they have different pharmacokinetics. So there's many consortia, which is actually very nice. There's not a lot of pharmaceutical companies interested. Anybody knows why there is not a lot? They develop a lot of antihypertensive drugs and cholesterol lowering drugs, but there's not a lot of interest. Anyway, why is there no big pharma company developing TB drugs? Yeah. It's a very complex disease. Yes, that's definitely one reason. For example, when you want to develop the 25th beta blocker, antihypertensive drug, it's very easy. You just have to measure the blood pressure, and you know whether the drug will work or not. But for tuberculosis, there is much similar surrogate marker for response. You have to perform these lengthy trials. Yes, it's a complex disease, and you have to perform lengthy trials. But that's actually not the main reason. The main reason is that there is not enough return of investment for pharmaceutical industries. So the development of a drug takes about $1 billion, And TB is mainly occurring in what is called developing countries. And they simply, although there are many, many patients, they cannot earn enough, which is a bit, well, what's the word in English? Yeah, it's a bit embarrassing actually. But you have to realize total treatment for TB, 6 months treatment, costs about $10 for each patient. And it means that the pharmaceutical company, they cannot earn a lot of money. They cannot ask, let's say, $100 for their new drug, because it can simply not be paid by them. One of the reasons why we are still stuck with this awful disease. But now there are many consortia. These are academic consortia. No pharmaceutical companies, some of them small companies. And UPAT is part of these consortia as well. And we are also looking at stratified medicine because there have been several big trials trying to shorten TB treatment from 6 months to 4 months, or there was even a trial last month published on presented on 2 months treatment. And the reason is, and what we see is that actually for many patients, 4 months would be enough, but there's always some 20% of the patients remaining who fail treatment. So it would be very nice if we could identify those patients who respond well, who only need a 4 months treatment, who apparently do not have a lot of dormant bacilli. And that's the new concept of stratified medicine. I was part of a study in children, which was published this year recently. And it was, yeah, look at the title, shorter treatment for tuberculosis in children. Only 4 months of treatment. In children with non-severe tuberculosis, according to some criteria, which is really a big breakthrough because it means that hundreds and thousands of patients, children in Indonesia, everywhere, they only need a short treatment. Very nice for the healthcare system because all these patients and children need to have their treatment under observation, directly observed treatment, to ensure that the adherence is good. Of course, we did a pharmacokinetic sub-study. I will not bother you with details, but we saw that the concentration were low. You see here, still quite low in children, which means that we can give higher doses, achieve higher exposures, and maybe treatment duration can be shortened to 3 months or maybe 2 months. Okay, now the world had wakened up. And there is quite some research now ongoing on new TB drugs. So this is what we call the pipeline of drugs. You know, there is the preclinical phase of drug development. Then there is phase 1, 2, 3, and 4 of drug development in humans. And you see there is a whole battery of new drugs coming on. Mainly academic institutions with some small pharmaceutical companies. And actually there have been new TB drugs introduced to the market. 3 new drugs in the past 10 years, Vedaclin, Elamine, and Predom. Okay, so this is clinical trials in consortia, and of course you want to go through this chain, and in the end it should be applied in clinical practice. So that you as medical doctors can prescribe the drugs. So what's translational pharmacology? It's from a word in Latin word transnational, which means lastly, transfer of information from the one phase to the other, and in the end, to the clinical practice. It's bench to bedside. And I'd like to give one example of this in the field of pharmacology of TB drugs, and it's the concept of high-dose revenge. As I had explained, and I'm giving this example because OPAT and household solution have played a very important role in developing this concept. And rifampicin is the most important TB drug. It's causing a lot of drug-drug interactions, just like I had shown for moxifloxacin. It has a very intense red color. So when you take the drug, the urine and, for example, your saliva, but also how you call your eyes, the fluid in your eyes, is also colored red or orange or pink. So people who are using, I don't know the word in English, You don't want glasses, but you have lenses. What's the word? Contact lenses. Yes, they are colored by rifampicin. You need to use contact lenses which are disposable. But it's a very, very strong. It's the strongest CB drug. And yeah, what we had thought in the beginning and others as well is that we did not use the optimal dose of rifampicin. So this is a concentration effect curve. Here you should increase the concentration of rifampicin. And when the concentration is decreasing, you hope that the probability of good response will increase. This is a hypothetical curve. You hope that the response will be better, and at the same time, you hope that there will not be more toxicity at the same time. So this is the ideal picture, and we think that with rifampicin, we are, some 15 years ago, we thought we are somewhere here. This is the drug concentration. There is some probability of response, but we can increase the dose and increase, especially the concentration, because this talk is about concentration. Oh, that's the wrong direction. So first we have performed a study in mice. So this is the preclinical pharmacology, and what you see here is that the mice, they are taking rifampicin, they are infected with Mycobacterium tuberculosis, with human Mycobacterium tuberculosis. And then the poor mice are being dissected, they are killed after a few weeks of treatment. And then you can count the amount of colony-forming units in the pulmonary tissue or in the spleen. And this is happened when you have untreated mice. Yeah, they have a very high load of colony-forming units. They have a lot of mycobacteria in the pulmonary tissue. But when you give rifampicin, you see the load after 3 weeks is decreasing. But you also see, and this was the aim of this study, that when you give a higher dose of rifampicin, double dose, 4 times higher, 8 or even 16-fold higher dose, you see, okay, those mice are doing better. They have a lower load of bacteria. But yeah, the dose is quite high, 16-fold higher. Can that be tolerated in mice or in humans? So that when we started to perform, we went to the second phase, which is clinical pharmacological research in small patient groups. Again, these were patients from Bandung. This study was also performed at the Sanatoriums hospital. This is again a pharmacokinetic curve. We were not very brave. We were very careful. We only gave a very small increase in dose of rifampicin to the patient. We only have 30% increase. These are not mice. And the ethical review board would not have accepted. But you see, this intervention is effective from a pharmacokinetic point of view. Concentration is somewhat higher, area of the curve is somewhat higher. And this was one of the first studies on the concept of high dose rifampicin. And what we have done then is that we have step by step increased those humans and tested whether it was safe and tolerable and whether it was more efficacious. And this was here in Bandung and also in Jakarta, this was studied with the most deadly presentation of TB, which is TB meningitis. And the mortality is really up to 50% with TB meningitis. So if you want to use this concept of high dose rifampicin, yeah, those patients are really in need of any possible advantage. And we also know that rifampicin, the most important TB drug, did not penetrate well across the blood-brain barrier and the blood-CSF barrier. So we have performed 3 studies. We means that Indonesian, Netherlands collaboration on this concept of high dose rifampicin. And I'd like to show you some graphs from the 3rd study. First author, Sophia Tibian, a neurologist from the Sanatoriums hospital. And what you see here is, you see here the peak Cmax, it's the peak concentration of rifampicin in some patients who use the normal dose of rifampicin. You see the peak concentration on average is about 5 to 10 maybe. But when you increase the dose, you double the dose, you see that the peak concentrations are increased. And when you triple the dose, the concentrations are even higher. You see there is also a large variability between patients. Some patients have a very high exposure, which may cause adverse effects, and others have. But you see, there are no patients with low exposure to events. And the same applies to the area in the curve, the total exposure in plasma. Most importantly, of course, is what is the concentration beyond the blood-brain barrier. This is the concentration in cerebrospinal fluid. You see it there. And you see, yes, this higher concentration in plasma also translates to a higher concentration in CSF. So that's very nice. Concentrations are higher when you give a higher dose of rifampicin. It's quite logical, actually. But does it also translate in better response? Remember my picture about adherence, pharmacokinetics, pharmacodynamics. Concentration was the intermediary link. Is it true for rifampicin as well? So I'm showing you another graph. This is not a pharmacokinetic curve. This is a survival curve. Kaplan-Meier survival curve. Here you see the proportion of patients who are surviving from TB meningitis. These were all patients with London. And here you see the time after start of treatment. And normally we have the purple line. You see that after 26 weeks, half a year, only 50% of patients is surviving. That's really horrible. But then when you increase the exposure to rifampicin by giving a higher dose, you see mortality, the proportion of patients who survive is increasing. So the higher concentration in CSF and protein brain tissue also caused better survival. So there was an increase in survival from 50 to 70%, which is actually quite good for a very simple intervention with just one of those 4 drugs. And this is now being investigated in a worldwide trial in Africa, in Indonesia. You see, UPAT is collaborating, University of Indonesia also collaborating. We are also involved from the Netherlands. And this study is ongoing as we speak. So it should confirm, it's a phase 3 trial, should confirm the results of these other trials. And then eventually, of course, so this is performed, this is the third phase of translational pharmacology. It's the research in big consortium. We cannot do that on our own. We need colleagues from University of Indonesia and from University from South Africa, people from the United States. This is consortium-based research. But in the end, of course, you want to translate all this to the patient care. And actually in RTB Referral Center, the old-fashioned building that I've shown you, and also in our new building, we are actually applying the high dose. In the Netherlands, we do not have many patients with TB meningitis, but all patients do already get the high dose of those because we think there is already enough evidence to justify. I always think when I had to treat my own mother or brother, I would also advise the high dose of those. The advantages are bigger than the disadvantages. But formally, we have not reached the highest level of evidence yet. So we are doing this. We are giving high dose of a whole handful of pills. It's quite some pill burden. It's not easy for patients. They have to ingest a lot of pills. Okay. So this was my example of translational pharmacological research. It's about high dose of rifampicin. Very simple but very efficacious concept. And it was studied in mice and then small groups of humans, bigger group of humans, and it's already being applied in patient care. With a large involvement here from researchers from London. And it's all about concentrations. That's the message that I would like to convey. It's not about the dose. The dose is interesting, but in the end, you have to reach effective concentrations in the blood and in TB meningitis in the CSF or in brain tissue. I'd like to say something about patient care. So we are actually also measuring concentrations of drugs in the context of patient care. We do that for gentamicin, for digoxin, for anti-epileptic drugs. We measure those drugs in plasma and in serum in individual patients, and we adjust them. So that's called therapeutic drug monitoring. This implies that it is a little bit passive monitoring. So personally, I like the term target concentration intervention. So what you do is that you really go to individualize drug dose for each individual patient. You measure the plasma drug concentration, and then you're going to adjust the dose. If you have a patient with very high concentrations, you're going to decrease the dose. If the concentrations are too low, you want to increase the dose in that individual patient. And you want to bring and to keep the plasma concentration from certain range. It's called therapeutic range. You heard about that? It's the optimal balance between efficacy and toxicity. It's not a dose, it is a concentration range. The dose is not relevant. It's a concentration that you achieve. So this is really precision medicine. It's not one size fits all. And this is what we're currently doing in TB treatment and in many diseases. No, the aim is rather really to measure and suit to each individual patient. And the aim is, of course, we want to optimize response in the individual patient. If the patient is not responding well, for example, patients with convulsions, epilepsy, we often see when we measure drug concentration, oh, they are too low, or for the one reason or the other reason. You should not be surprised. We should increase the dose to prevent emergence of resistance, to explain adverse effects. You can also see drug-drug interactions, or, for example, in patients with renal function disturbances, you can see that some drugs are accumulating too much. And you can also detect non-adherence. But that's actually not that good, because the drug concentration only tells something about the last dose. How can you measure adherence in the patient? How could you do that? As a medical doctor, I think it's very important to somehow verify that the patient is compliant. How would you do that as future medical doctors? Simply ask the patient, what do you think that the answer of the patient will be? Yes, doctor, of course. Yes, I'm taking the drugs. But that's one technique you can ask the patient, but there will be many socially desirable answers. But there's also very short questionnaires, which are validated and which have a more objective means of measuring the response of the patient. 4 or 5 questions. They often also have very simple social desirable questions. For example, do you ever hit your brother? And if people say no, then they may be lying with respect to non-adherence. The questions are a little bit more subtle. You can, of course, do pill count. You can ask the patient to bring the pills, or you can ask the pharmacy to check whether the patient is coming at frequent intervals. But otherwise, what's more, you can measure the drug again, but that's a problem because it's only the last dose. You can measure drugs urine, which is not very reliable either. But for example, patients with rifampicin, they should have pink urine. It's a typical question that 2 grossest doctors are posing. What's the color of urine? Yeah, it's yellow. Okay, then there's a problem. The patient is not taking the drug. What we are currently investigating in Tanzania is the patients receive a box, pill box. When you open it, it records the opening. And then a signal is sent to a computer, and the doctor knows whether the drug has been taken or not, or at least when the box has been opened or not. You can also send text messages to a patient. most of the patients have a phone and remind them about taking the drugs. And when the patient is coming for an outpatient clinic visit, then you can, the doctor, you can show the patient his or her own intake behavior, and you give feedback based on the results. Okay, therapeutic drug monitoring, measurement of drug concentration. I know it's not that common yet in Indonesia, but I think it's the future. Precision medicine. And again, it's about measuring drug concentrations. What do we do in our TB referral center in the Netherlands? We do not measure all the patients. We only measure the ones who are referred to our center and they have complex TB. They have gastrointestinal abnormalities. For some reason, they may not absorb the drug. They have renal function disturbance. And especially the patients who are not responding well, whose sputum or saliva still contains the microbacterium. Or those who have a relapse, they may have had low concentration, even if they have taken their drug appropriately. So that's why we measure the drug concentrations. They have to come for a whole day, and to the outpatient clinic, we take blood at 2 hours after the dose, 4 hours, 6 hours, and in this way we can catch the concentration, and we can also estimate the total exposure area under the curve. Quite complex from a logistical point of view, because some of the drugs are very unstable. They have to be transported on ice. There is not a lot of evidence for this practice. There have been no prospective clinical trials, but we know from our experience that this can really be an exciting tool. I think we have saved a lot of patients with this, and the alternative is to watch, to wait, and to hope for the best. So when you can analyze those drugs, because you do research, you may use the same assays for patients. And this is also being considered now in hospitals. Okay, then there is capacity development, which means collaboration in research. Also in TB research, so I'm part of a collaboration, Dutch, Indonesian collaboration. So we help our colleagues in Indonesia and also the other way around to study and improve our healthcare programs. For example, this is a picture. There's a pharmacological lab at UNPAD, which was developed with our help. All our analytical methods were copies, and now it has become an independent and renowned pharmacological laboratory, which is performing this kind of pharmacological, pharmacokinetic studies. There's also a guest coming over to our center. This is the kennels. Here you can see one of the kennels in Amsterdam with a colleague of mine with 2 guests from Tanzania. It's also very important to collaborate because the career perspective in research. It's sometimes complex to develop a career in research, both in the Netherlands and Indonesia. And when we can exchange, and especially when we can work together, it helps. And as I said, building of pharmacological infrastructure. So what should you remember from this talk? You should remember, but you already know, I think TB is still the #1 infectious disease killer. I think this year there will be more death again due to TB than due to COVID. It's more than HIV infection. It's more than malaria. #1 infectious disease killer. The main message is that the drug concentrations are important. That's important for TB drugs, but it's important for all drugs. Drug concentrations are intermediary. So look through your pharmacological glasses. That's why you have pharmacology, also pharmacokinetics, pharmacodynamics in your curriculum. We still want to design dosing regimens that are fixed, which means that all the patients receive the same dose. But the dose should be optimized. Like high dose rifampicin, we have been giving rifampicin at a much too low dose for decades. For example, to those patients with TB meningitis. So we're aiming for fixed regimens, but they should be pharmacodynamically optimized. And we know this through translational research. But Yeah, you can also use precision medicine. Individualize the dose based on drug concentration. At this moment, it's in Indonesia. I think it's still expensive. It's not cost effective yet, but I think it will become less expensive. And we want to get rid of equipment, expensive equipment, and use immunoassays for maybe simple point of care. So, as a medical doctor at the side of the bed or a nurse, you simply take a drop of blood and you get the result immediately. Is concentration low? It's high? It's intermediate? Well, I think I've shown that pharmacological TB research, any research, requires collaboration, local collaboration, national, international, and there is quite some cross-fertilization between research and patient care. So we researchers, we are motivated because what we see in the clinic, and we want to transfer all our knowledge back to the clinic. And that's the nice thing about pharmacology. I like to raise your enthusiasm for pharmacology a bit more, because there is a thin line between what you learn and what you can implement in a patient. And I think that's the end of my presentation. I'd like to thank my colleagues also at UMBAT and at the Hassan Hospital. This is the research done a few years ago. Thank you very much. In time? Yeah. Okay. Good.
Thank you. 15 minutes left. Okay. Any questions for student? No? Okay. Yes. Okay. Good morning, Professor. Thank you for your presentation. I would like to ask a few questions regarding this.
Yeah.
Okay, so it is said that the study that conducted right now is researching for a high dose of rifampicin, and it is resulting as high dose of rifampicin is causing a high respiratory rate in pneumonitis patients. So my question is, that can this high dose of rifampicin causing drug resistance? And if it can, what are the precautions taken in this study? Thank you.
Yeah. Thank you for being so brave and pose the question. Yeah, so indeed, based on the 3 studies that were summarized in one meta-analysis, I showed the Kaplan-Meier survival curve. There is quite a reduction in mortality, but you have to realize these are phase 2 studies, small patient groups. I think the total number of patients in that meta-analysis was maybe 150. So it really has to be confirmed. But I'm quite confident that it indeed helps to increase mortality. And now your question is, can it also cause resistance? Yeah. So in general, resistance to rifampicin is a big problem. So when you have resistance to rifampicin and to isoniazid, 2 most important drugs, that's already called multi-drug resistance. So in general, the resistance is a big problem. But you can imagine that if you have higher concentrations of rifampicin, you may actually prevent the emergence of resistance. And you may even overcome the resistance. Higher dose of rifampicin may pass when there is some intermediate susceptibility, it may overcome the susceptibility. So, and you have to realize that resistance is emerging when there are too low concentrations of antibiotics, because then there will always be a few mycobacteria that can resist the low concentrations, and those bacteria, they are actually surviving, whereas the other ones, that brothers and sisters, they are being killed. This is the principle of selective pressure, and this is survival of the fittest, Darwin. So low concentrations of TB drugs favor the emergence of resistance. So when you give high dose, you actually prevent, that's what we think, you prevent the emergence of resistance. Of course, we should be careful whether these high doses and concentrations, whether they are also tolerable to the patient. And it appears that it's reasonably well tolerated. In patients with TB meningitis who pass away, 50% of them, tolerability is a little bit less important, which should survive. Yeah? That's answer to your first question. We have another question. No? Good. Thank you.
Okay. Thank you. What? Thank you.
Thank you for this. For the discussion. I'm the students, and maybe my question is today we know about the next step, which is asked and show what are drugs the microbacterium are resistant to. Is there another way that maybe is developing a way to another way other than the expert can show drug resistance to TB, maybe like that. Is there a simpler way? Because we know that not every hospital has a team expert tools, and it is necessary to identify the drugs.
Yeah.
Thank you.
Well, that's a very good question. I'm surprised that you know about Gene Expert, which has been introduced a few years ago worldwide, and which is actually a rather simple system to detect resistance to the most important TB drugs. It's much more easier, and it can be the operation of the system is quite simple. Even pharmacists and I can simply you can learn how to use equipment very easily. And it's much more easy than the more complex microbiological techniques. But as far as I know, this is actually one of the easiest, the most convenient techniques to detect drug resistance. But now I'm turning, because I'm a pharmacist, I'm turning to a real microbiologist, Dr. Lydia Shaidia, who may answer your question. Are easier means of detecting resistance than Gene Expert.
Okay, thank you for the questions. Well, actually, for now, in the programmatic condition, and we use the expert for sure. Is there anything I say easier than the expert? I think there is, but for our programmatic condition, it is not yet used by us in our program. But I am very sure that there is ways much easier. Assay actually is expanding and is being evaluated in the clinical, in the diagnostic for the use in the TB program. But for us now, it is still.
Yeah, I'm sure as a pharmacist and pharmacologist, I would be very pleased if we would have similar equipment like Gene Expert to measure TB drug concentration. But in the end, we want a simple bedside. Yeah. I saw a question over there. Not a brave student.
Thank you, Professor, for the presentation. I want to ask, is there a possibility to compile the most effective drug combination for each individual from the start of treatment without the need to go through the monitoring stage, considering that the level of compliance, especially in Indonesia, is still low? Thank you.
That's a very interesting question. It's not about the drug concentrations, individualization based on drug concentration, but the choice of the drugs. Well, for the majority of patients, the microbacteria that they carry with them are susceptible to the first line TB drugs. So then we can simply use the first line TB drugs, isoniazid, pyrazidamide, and atomic. But the situation that you describe is very similar to the situation for multi-drug resistant TB, where there is a battery of drugs available, maybe 10 relevant drugs, but we do not know which drugs to choose. And there are various means of administering MDR-TB treatment. You can simply give a big combination of those drugs. For example, there's one standardized regimen with 7 drugs, and in practice, the resistance is often not measured. And then you hope that the bacterium is responding to at least some of these drugs. But what is also taking place at this moment is indeed individualization of choosing drugs. So then a microbiological laboratory is measuring the resistance, and based on this, medical doctor chooses the drugs. So you ask, you send in a sample, a sputum sample, and then you get results from a genotypic test or a phenotypic resistance test, whether the bacterium is susceptible or resistant. And then based on this, the microbiologist advises you have to take this and this drug. The problem is, it often takes time for the phenotypic test and also for the genotypic test to obtain the result. But the answer is yes, this is taking place at this moment, especially for the MDR-TB. Thank you for your question.
Okay. What?
Good morning, everyone, officers and officers. Let me introduce myself. My name is Aldo. I'm a third year medical student. Actually, my first question was taken by the other person that has asked, but so now the world is doing research on high dose of rifampicin, but what if after the translational stage, after we're given the higher dose of rifampicin, the resistance, the antibiotic resistance issue is still a problem. So the high dose of rifampicin becoming resistance again. Is there any research to combat, or the second option to combat this problem to avoid the resistance of high dose of rifampicin? Because it's not just, I think it's not just about the problem of the drugs, also the problem in the human behavior, the adherence, and etc. So I think that's my. Oh, I also have the second question. And the Netherlands, Professor, is there any regulations, maybe government regulation on antibiotic, so it could prevent the resistance of antibiotic? Thank you. I think that's all my questions.
Yeah. So thank you for your questions. Yeah, your first question is an excellent question. So what happens if this most important drug rifampicin is actually, can we lose it actually? And this is actually what is happening at this moment with the multi-drug resistant TB across the world. We are losing the currently available TB drugs, and we need new weapons. And that's why there is such intensive research now. I show a picture with the many compounds that are in the pipeline. And at this moment, there are various clinical trials ongoing to look for an alternative new regimen. And this new regimen also contains other drugs. I mentioned one drug, bedaquiline, which is a very strong TB drug, not only against MDR-TB, but also against drug susceptible TB. So we are currently looking for a new regimen. But what you should know that even for this new drug, bedaquiline, resistance is already emerging. So we should anticipate about the near future where we also will use this new drug. And it means in practice, to my opinion, that we should keep on developing new antimicrobial drugs, investigate new combinations,
and also not rely on just one regimen. You need multiple regimens. So the battle against the mycobacteria and other viruses will never end. That's a problem, and it also has to do with its evolution. The microorganisms, they will escape from our weapons. Yeah. So that's the answer to your first question. The answer to your second question is, yeah, there are strategies to prevent the further emergence of resistance, although it's very difficult. It's an immense problem worldwide. Now I'm not talking about TB, but about all other kinds of infectious diseases. And WHO thinks that antimicrobial resistance in 30 years' time will be the biggest problem, and also raise most costs, more even than cancer and diabetes level. So it means that we need a concerted effort, and it has to do with drug use in humans, but also in the veterinary sector, where there is a lot of drugs being used by animals. And when it comes to humans, for example, in the Netherlands, we are very close to using, monitoring the use of antimicrobial drugs, because the most important factor for resistance development is overused drugs. Too many drugs. Too many doctors prescribing drugs for any medical condition. So the use of drugs is being monitored. And for example, in hospitals, we have what is called antimicrobial stewardship, which means that if, as a medical doctor, you prescribe a drug, the committee will be behind you and check whether this is appropriate. Not literally, but we are checking, and there's a committee in our hospital that is checking all prescriptions on a daily basis. They go into the files of the patient and they pose the question, is it correct? And sometimes they contact the doctor and say, hey, this is not the best drug. And also for me as a pharmacist, on a daily basis, our pharmacy is checking whether there is some drugs for which we can do therapeutic drug monitoring, just to optimize the response and prevent the emergence of. Yeah. So the answer is yes. In the Netherlands, we have quite a firm program. And similar programs need to be extended across the world. And that's really very important. Also very important for Indonesia.
Okay, thank you. So when we have fever for 3 or 7 days, and in the Netherlands, we could be antibiotics from, right? But typically to get fever in 24 days, and then we don't know what is it infection, or the doctor would be prescribed antibiotics, but somehow the pharmacist would be assured that the patient already have the antibiotic or not, right?
There's also a role for the pharmacists, for the community pharmacists, checking whether the doctors are prescribing well, whether the duration of the treatment is not too long, and also assisting the patient in being adherent, taking the drugs in the right way with food. I think there's a world to win also for the community part. Yeah.
Okay, patient, and we are voicing for student of the system. This is, if I didn't explain it, you mentioned that the advantages of the virus or patient, correct me if I'm wrong, the advantage is more than the disadvantage. So I'd like to know more about how it does affect the body. Is it safe or it has another major effect
Yeah, thank you for your question. Indeed, what we are aiming for, and prevention is just an example, is to find the optimum dose for each drug. And then when you have optimized dose, you can combine the dose. And optimized dose and optimized concentration means that you should be in the therapeutic window, which is the window where there is a good balance between efficacy and safety tolerability on the other hand. It means that the majority of patients is responding well and is not having too much adverse effect. For an individual patient, it may still mean that the concentration is not tolerable, or that the concentration is actually not high enough. Now, in case of high dose prevention, those higher doses are reasonably well tolerated. We were concerned about hepatotoxicity, that's why we increased the dose of prevention. Remember the first study I showed from Bandung? We increased the dose only from 10 to 30 milligrams per kilogram because we are afraid of hepatotoxicity. Well, it appears there is not a very high rate of hepatotoxicity due to events. It's not a concentration-related adverse event. It's what we call idiosyncratic. It's not explained by the dose. So this is the case for events. For other drugs, yeah, you have to be careful indeed. But this is what I mean by fixed doses which are pharmacokinetically optimized. You should take care of the efficacy, but also the safety for it. Answer to your question?
Yes.
Yes? Thank you.
Okay, still any question? Student, for Zoom, still any chat? Want to ask question for online participants? Any question for the student? No? Ada? Oke. Oke, yang Zoom, yang online, ada yang mau ditanyakan langsung, boleh? Silakan. Langsung kita mau Oke, mungkin dari sini sambil tunggu yang online. Ada lagi? Anyone? So, maybe for me, as you know, students already learned about leprosy in tropical medicine system, right? So, they also are reconditioning there, copazimine and that so on. Okay, but it's different. The treatment only once month. What do you think? Do you have any experience or anything about this? It's different with the component.
Yeah. Yeah, as a pharmacologist, I'm actually quite surprised when a drug has to be administered only once a week or even once a month. But it means that there is a completely different interaction between the drug and the bacterium in this case, which is a little bit surprising because the lepra bacillus and the tuberculosis bacillus, they are really brother and sister. So I do not have an immediate explanation. But I know it works, it has been shown in clinical trials. So yeah, I think we should reason the other way around and try to explain that. For TB, it's very sure that this is suboptimal. For example, in TB programs, there used to be 3 times a week administration, also in Indonesia, up to some years from now, and it has been demonstrated that this is suboptimal. What we thought and what we know from pharmacology is the post-antibiotic effect. It means that when you give an uppercut to a bacterium and the bacterium is knocked out, then it will remain knocked out for a certain period. We call this the post-antibiotic effect. So this could be an explanation for what we see in the liver. But in TB, we have learned that the post-antibiotic effect is not strong.
Okay, well, okay, can we open my door? Open my door to Zoom, right? Okay. From here to there? Do you have any issue? Oh, yeah, okay.
Thank you, Professor, for the very insightful lecture for us. My question is, I would like to ask about the alternative treatment using the bacteriophage. Maybe it's a virus that specifically infect the bacteria. I know it's a bad idea, really. We literally inject the virus to our body, but then again, we compete against something that is with more drug resistance, and I think that the virus can mutate again to compete with the evolving bacteria. What do you think about it?
I think it's not a bad idea. I think it's a fair. And the only problem is that this idea has been quite some time now, and has been stations with French. Yeah, the results so far are not very encouraging. So, but still, I think that the concept is very good. Yesterday, I talked with a colleague of mine who is going to study this concept of bacteriophage, starting in the preclinical phase, but I guess other microbacteria and bacteria. So, but the results so far are very. I think it needs major investments and actually a pharmaceutical company with all its potential, because they do a lot to bring this concept a step forward. But so far, it's only something for the theory books. Yeah.
Okay, Edward, do you have a question? No, last time in Zoom online, is there anyone? Okay, I think enough for
Yeah.
the Q&A session. Thank you very much. Please propose from.
Thank you very much. Thank you for your kind attention, and I wish you a good day. Bye-bye.
Itu mereka cakap sama aku. Thank you, bro. Very, very nice. And therefore, I think accept it.
Yeah.
Yeah, we didn't expect that, but.
Oh, yeah. No. Oh, yeah. No, you don't have to wait for me. If you want to return, you can return. That's okay. Yeah, yeah. Yes, of course. Yeah.
You 15 minutes explaining what it is. Nah,